All right. Okay, so thank you very much, Odd Helge. Thank you, Christoph. Your excellent lectures. Can you hear me?
Yes, excellent.
Okay, so I think during our webinar, if I see the chatting screen, I think there were a little bit technical problems, and sorry about that. And thank you for your patience. And there was a lot of questions seen on the screen. And first, let's have the answering session to those questions. But there was some questions to me, so I will start the Q&A session. And there was question regarding the criteria, Doppler criteria, the Nutcracker syndrome, and specifically asked about the anterior and posterior Nutcracker. The old cases I showed you is the anterior Nutcracker, so-called. It means that the left renal vein anterior to the aorta. But there was the congenital variations, so-called retroaortic left renal vein. This left renal vein locates between the vertebra and the aorta. Then there's a compression between the vertebra and aorta, and the Nutcracker can occur. Then it's called posterior Nutcracker. I don't think we do not apply a different criteria, just probably the same criteria. But I do not have, I had the experience of some cases of posterior Nutcracker is not very much. So if there is if we see the precision of the aorta, and if we see the left renal vein, and if we see the compression, persisting compression between the vertebra and aorta, and if we measure the velocity and it is higher than the 80 or 100, then we can make a diagnosis of Nutcracker phenomenon. And if that patient had the hematuria or proteinuria or left flank pain without any explainable cause, then we can make a diagnosis of Nutcracker syndrome in those patients, posterior Nutcracker syndrome. So answer to the question, my answer to that question is we do not need to apply different criteria. And another very nice question regarding is there any, the flow pattern, Doppler spectral pattern difference between the Nutcracker patients and the normal left renal vein? I think that is a very nice question, and but the answer should be it's very variable, very variable. In some patients, for example, let's say the compression is very severe, and just intermittently we see the venous flow. So the venous during the cardiac cycle, the left renal vein flow stops for a while, and just a very short moment there is a jetting and stop and jetting, stop and jetting. I think that is the one pattern indicating that there is a very severe compression. And I think the most severe compression is we do not see any flow in dilated left renal vein, and we cannot detect any flow in left renal vein at compressed area. I think that is the most serious, most severe type of compression. But in those cases, usually there is some collateral pathways like gonadal through the gonadal vein or lumbar veins. Otherwise, left kidney cannot stay safe. And regarding related with that question, there was a question: how common is the Nutcracker syndrome with the pelvic congestion syndrome? I think there are cases of both have Nutcracker syndrome, having hematuria or proteinuria, and having pelvic congestion syndrome. let's say, a regurgitation of blood flow to the left pelvic area and having left pelvic chronic pain, then we can say that this patient has both syndromes, Nutcracker syndrome and the pelvic congestion syndrome. But it's not very common because if the gonadal vein acts as a collateral pathway to the compression of left renal vein, then left renal vein pressure becomes lower, and usually then Nutcracker syndrome, we do not have a hematuria or proteinuria, but just we can see the Nutcracker phenomenon, but without Nutcracker syndrome. So it's the same as the pelvic congestion syndrome. There's a varicocele in men. So in both conditions together, it's not very common. It's there are, but it's not very common. That is my answer. And I think those questions were given to me, and I think I answered all the questions to me. And if there is more questions, please give us during our this Q&A session. And can I invite Odd Helge? Did you receive some? Christoph?
Yes. Yes. Can you hear me?
Yes.
Yes, I have received 3 questions. The first is, what is the current criteria to diagnose polycystic liver disease? Number of cysts, etc. Well, as you know, there are 2 types of polycystic liver disease. Usually, and in most cases, around 90%, it's connected to polycystic kidney disease, which is an autosomal dominant disease. And only 10% you will find an isolated polycystic liver disease. The number of cysts is not the critical issue here. The most important clinical part is actually to decide when the liver fails, meaning that you have to take blood samples to follow your patient. Regarding number of cysts, I like to say that when you give up counting cysts, then you are probably approaching the diagnosis of polycystic liver disease. The most important thing here is that the disease is progressive, the size of the cyst increase, and the number of cysts increase during follow-up. And you have to decide the right time for transferring to liver transplantation. That's the main issue. The next question, let me see. Any findings to differentiate hepatic vena cava versus Budd-Chiari syndrome on ultrasound or otherwise? Well, of course, you have a lot of help from your color Doppler to actually detect or not detect thrombus material inside the liver or just in the cava vein. Usually, this distinction is not very difficult, but if you have a Budd-Chiari syndrome, some of these veins in these thrombus material in the hepatic veins can actually expand into the cava vein. But the other way around, the thrombus extending from the cava vein and into the hepatic vein, that, for instance, might occur during cancer of the kidneys, you will usually find Doppler signals more centrally in the liver hepatic veins. So normally, it's fairly easy to distinguish in Doppler ultrasound or even contrast-enhanced ultrasound alone. The next question is, can we suspect first bout of hematemesis using spleen elastography kilopascal values? Well, usually we tend to say when we perform elastography of the liver, when the kilopascal exceeds 20 kilopascals, then there is a risk of portal hypertension that may give rise to variceal bleeding from the esophagus. However, the stiffness of the spleen is much higher than in the liver. So a normal situation there will be with spleens stiffness around 16 to 17 kilopascals. So if you go to cirrhosis and F4 fibrosis, there are some studies that are actually quite variable in results, but there may be an average above 35 kilopascals would indicate a cirrhotic liver when you measure the spleen elastography. However, I haven't seen any distinct notion regarding risk of bleeding, but you could suspect if you make a spleen assessment above 40, above 50, the risk of bleeding from esophageal varices would actually increase. But there are no exact data, and actually there's a great variation in stiffness measurements of the spleen in the literature. If anyone would like to add something, maybe Christoph, would you like to add something there?
Completely agree.
If not, I think I have answered. If there are any more questions? No, I think that's were the 3 questions for me. Thank you very much.
Yeah, it seems that I can answer some questions which I found written here. What are the earliest signs of mesenteric ischemia in the bowel? And first of all, we have to differentiate the acute and the chronic mesenteric ischemia. And the acute one might be embolic, thrombotic, focal segmental ischemia, or non-occlusive ischemia. And they are mainly in superior mesenteric artery. And the earliest signs we can see in the ileocecal region at the very end of that vascular bed. It's not often dominant. That means a little bit of bowel wall thickening, loss of layer structure. We call it dirty bowel. But more important, you can measure the inflow from superior mesenteric artery. And there's a lying detector. So if you have a flow which is less than 80 centimeters per second, only diastolic flow, you have a double, only systolic flow, you have a double systolic peak, and you have no diastolic flow at all. It shows very high resistive index, and it's the earliest sign of acute superior mesenteric artery ischemia. It's not very often recognized, but if you look for that, it's a very sensitive and early sign. There are no studies on earlier diagnosis, but I'm sure if you do it at the very earliest moment, you might improve the prognosis. The chronic mesenteric ischemia is more often in the inferior mesenteric artery, and it is not acute, it's a chronic setting. So that was the first question. Second question, what are the early, any significance of submucosal polyps? Like endorectal or endoscopic ultrasound, we can nicely depict 3, 5, sometimes 9 layers of the bowel wall. And that means it's the imaging method to best diagnose mucosal, submucosal infiltration. And therefore, my answer is yes, we can diagnose by ultrasound. There is a question, what is a typical Seus pattern of gastrointestinal stroma tumors? Very nice question. It's an eye-catching feature. You have a lesion in the muscle proper layer, sometimes in the submucosa, which shows a very characteristic enhancement in the very small lesions at an early stage. It shows non-enhancing areas in a highly vascularized muscle proper layer structure, whereas leiomyoma or most other tumors in that location do not show such non-enhancing areas at a very early stage. 2 centimeters in size, 3 centimeters. The larger the size of other tumors, they show also non-enhancing areas at a certain stage. So GIST is a very eye-catching consciousness ultrasound imaging characteristic. So let's see, there are more. It's the same question with the spleen elastography. Is midline congestion syndrome a reliable entity as a variant of Nutcracker? No, that was for Xiong.
Yes, yes, I saw that question.
I don't see any other question. Thank you so much. Hopefully, I could answer them.
Okay, thank you, Christoph. And I saw the question that Christoph mentioned just. I just saw the question. The question was: is midline congestion syndrome a reliable entity as a variant of Nutcracker syndrome? Any significance? I'm not familiar with this the midline congestion syndrome, but as far as I know, it is just a not a real disease entity, but it's just a hypothesis that something in our midline of the body, something like a compression occurs just like a Nutcracker syndrome and cause a lot of the symptoms from the head to the toe. I think that is a concept of midline congestion syndrome. But so I think that I cannot answer this question, but I think it's an interesting concept because I know that I think that I have a lot of experience with Nutcracker syndrome, but I have to confess that what I know about Nutcracker syndrome is much less than what I don't know. Still, a lot of things I don't know, and but one thing I know is a very variable, very dynamic, with a lot of wide spectrum, and so there's a lot of things we need to look for. And the other question I had is really how common is Nutcracker phenomenon and Nutcracker syndrome? As I said, it's not rare, probably not rare, and it's probably common, but how common? Let's say, after I retired from my university, so National University Hospital, I said, just 1 year, I worked in the kidney clinic with my nephrologist. So there's basically kidney patients, and we analyzed how many cases ultrasound we done, and how many cases Nutcracker phenomenon was there, and how many cases Nutcracker syndrome. We can make a diagnosis in Nutcracker syndrome, and roughly about 25 to 30% of the patients have a compression effect of left renal vein. You see, abnormal compression effect of left renal vein by one of the 3 types I mentioned before. So it's quite using the criteria 80 to 100 centimeters per second. Let's say 25 to 30%, there's a phenomenon. And about 1/2 of them has a proteinuria and the microscopic hematuria or left flank pain, and their symptom or signs cannot be explained by others. So we can say that those patients, about half of the phenomenon is a syndrome. That is a rough number, rough figure I have. So it's a very common phenomenon. And as I said, still we do not know what is the real criteria. But you know, if we apply the principle, Bernoulli principle with the flow dynamics, we can theoretically calculate the pressure gradient between 2 points if we know the velocity of those 2 points. And if we apply normal value, 40 centimeter here and 20 centimeter here, and the theoretical pressure gradient is less than 0.5, let's say a normal. And if we apply 80 and 20, theoretical pressure gradient is 2.4 millimeter mercury. If we apply 100 centimeter per second and 20 centimeter, the theoretical pressure gradient is 3.8. So between 80 and 100, there is the venographic catheterization criteria, 3 millimeter mercury is exactly there. So the Doppler criteria, 80 and 100 is quite equivalent to the venography. The venous catheterization pressure gradient is 3 millimeter mercury. So I think it's reasonable to use 80 or 100 centimeter per second as a criteria. And if we use that criteria, as I said, many people belongs to that criteria, means a Nutcracker phenomenon, and about half of them, if we see their urines, maybe they have the trace proteinuria or trace microscopic hematuria, and no articles explain that. And then we can make a diagnosis of Nutcracker syndrome to the patients. If we use that as a scenario, it's quite common disease entity, really. Okay, so is there any other comments of Helge or Christoph? And as I think we answered to the all the questions on the question screen. And the last thing I would like to announce is that if anyone need a certificate of attendance to this webinar, please email to WFUMB. And this webinar is recorded, and we will publicize the video on our WFUMB website within 48 hours. So again, thank you, Odd Helge, Christoph, speakers, and thank you all the participants, and also thank you Lynn and Suzanne for technical support. And okay, bye. Thank you very much.
Bye-bye.
Take care. Bye. Bye.
Bye-bye. Thank you, Sion.
Yeah, thank you. Okay, so stop broadcasting.
Beautiful day.
Okay.